right, today we're going to crack one of the most common puzzles you'll see in the clinic. We've got two conditions that look and sound almost the same on the surface, but underneath, they are totally different beasts. Getting this right is a huge deal, so let's jump in and solve the case of otosclerosis versus OME. So picture this, a patient's in your chair, and the tests show a conductive hearing loss. Right away, your brain starts racing. What's the culprit here? Is it a problem with the tiny bones in the middle ear, or is there maybe some fluid gumming up the works? This is where our detective work really begins. And here's the heart of the problem. The reason this is a puzzle at all. Both otosclerosis and otitis media with effusion, which we'll just call OME, show up with that exact same conductive hearing loss. You'll see it on the audiogram as a classic air-bone gap, right? Sound just isn't getting through the middle ear like it should. This one big similarity is exactly why we need a solid game plan to tell them apart. Okay, let's meet suspect number 1, otosclerosis. The best way to think about this is like a mechanical problem. It's an issue with the bones. Basically, there's this weird bone growth that happens around the stapes, one of those tiny little ear bones, and that growth literally locks it into place. It can't vibrate, so sound can't pass through. It's a bone problem, pure and simple.
Now for suspect number 2, OME. This is a whole different ballgame. It's not a bone problem, it's a fluid problem. Instead of a bone being stuck, you've got fluid filling up the middle ear space where it should just be air. This gunk just dampens everything, kind of like trying to hear underwater. It stops the eardrum and bones from vibrating properly, blocking the sound.
So, we've got our two suspects. Where do we even start our investigation? Well, the first place, and honestly the most important, is the patient's story. What they tell you is your first and often best set of clues. Let's see how this plays out. You know, just listening to the patient can give you a massive lead. Think about it. Are you talking to a 35-year-old woman whose hearing has been slowly fading for the last couple of years? Man, your mind should be screaming otosclerosis. But what if it's a little kid whose mom says his ear has been plugged up ever since he got over a bad cold last week? That story points straight to OME. Even what they complain about, a low-pitched ringing versus that annoying feeling of fullness, it's all part of the puzzle. Okay, we've listened to the story. Now it's time to actually look for some physical evidence. The otoscope comes out. This physical exam is our next big step. And honestly, it can sometimes solve the case right then and there. And whoa, look at this. It is literally a night and day difference. With otosclerosis, you peek inside the ear and the eardrum looks perfectly fine, totally normal. But with OME, it's a completely different scene. The eardrum looks dull, maybe it's sucked inward a bit, and you might even spot some telltale air bubbles or a fluid line behind it. The visual evidence doesn't lie. This right here is a clinical gem you've got to remember. If the patient is telling you they can't hear well and their tests confirm it, but you look in their ear and everything looks pristine, your brain has to immediately think, okay, the problem must be deeper, like that little stapes bone that's gotten stuck, that's otosclerosis. All right, we've got the story, we've got the visual. Now it's time to bring in the big guns, the hard data to really lock in our diagnosis. The objective tests are where we separate a good hunch from a proven fact. When you look at the audiogram, otosclerosis often leaves a very specific calling card. It's called Carhart's notch. It's this funky little dip you see in the bone conduction line right around the 2000 hertz mark. What's cool is this is actually a mechanical quirk caused by that stuck stapes messing with the inner ear's natural vibration. It's a huge clue you just won't find in a case of OME. So we're building a pretty strong case with all these clues. But is there one test, one piece of data, that acts like the final nail in the coffin? You know, the smoking gun that just clears up any doubt? Oh yeah, there is. It's tympanometry. This test checks how well the eardrum moves, and the results couldn't be more different. For otosclerosis, that whole middle ear system is stiff, so you get a shallow little peak. That's a type AS. But with OME, the fluid behind the eardrum stops it from moving at all. You get a flat line, a type B. That right there, that's your smoking gun. So, there you have it. We've gathered the clues from the patient's story, we've looked at the physical evidence, and we've analyzed the hard data. We can now confidently close this case and make the right call. Let's lay it all out one last time. Just look at how neatly this all lines up. When you have a young adult with a slow onset, a perfect-looking eardrum, that special notch at 2K, and a type AS TIMP, that is a textbook case of otosclerosis. On the flip side, a kid who just had a cold, a yucky-looking eardrum, a flat hearing loss, and a type B TIMP, that's ONE. No doubt about it. The patterns are just crystal clear once you know what to look for. And this, right here, is why all this detective work matters so much. Because getting the right diagnosis sends the patient down two totally different roads. For otosclerosis, we're talking about options like a very precise surgery, a stapetotomy, or maybe hearing aids. But for OME, the plan might just be to wait and see, maybe try some medicine, or do a simple procedure to put in ear tubes. Making the right call from the start is absolutely crucial for taking care of the patient properly.